everyone, and welcome to our webinar on canine osteosarcoma. My name is Mandy Albert, and I am the President and Executive Director of the Greyhound Health Initiative. Today, Dr. Nicola Mason will be discussing the clinical symptoms, diagnosis, treatment, and new immunotherapeutic approaches to preventing and treating metastatic osteosarcoma. In addition, Dr. Mason will discuss ways in which our great community can get involved in helping us find better treatment options, as well as an update on the research Dr. Mason is currently conducting at the University of Pennsylvania. Here is our agenda for today. Please type any questions you have in the Q&A, and they will be answered at the end of the webinar. Please use the chat function for any technical issues you are having with Zoom, and we will do our best to help you troubleshoot them. For those of you who are not aware, the Greyhound Health Initiative is a nonprofit organization committed to improving the health and well-being of sight hounds around the world. We build awareness of their unusual medical characteristics within the veterinary and adoption communities through our education, outreach, and research programs. This webinar is part of those programs. If you would like further information on our educational resources, please visit our website, ghi.vet, and click on Educational Resources. You can filter the options to the specific subject you are interested in, and then browse through the articles and videos. You can also follow us on LinkedIn, Facebook, Instagram, and YouTube for the latest educational information and/or future events. It is my pleasure to introduce Dr. Nicola Mason. Dr. Mason is a professor in the Department of Pathobiology and holds the James and Gilmore Endowed Chair Professorship at the University of Pennsylvania School of Veterinary Medicine. She received her veterinary degree from the Royal Veterinary College in London and her immunology PhD from the University of Pennsylvania. She performed her postdoctoral fellowship in cancer immunotherapy with Carl June at the Aberson Cancer Center at the School of Medicine at Penn. Dr. Mason leads the NIH NCI supported pre-medical cancer immunotherapy network for canine trials. Her pioneering work with the live recombinant listeria vaccine in dogs with osteosarcoma earned her the One Health Award for excellence in promoting One Health initiatives. A clinical trial evaluating this recombinant vaccine in human pediatric patients with metastatic and relapsed osteosarcoma is currently enrolling. Current studies in the Mason Lab include evaluation of genetically engineered chimeric antigen receptor cells as an off-the-shelf platform for canine patients with either primary appendicular osteosarcoma or metastatic osteosarcoma and CAR T cells for canine patients with B-cell lymphoma. She also has developed several monoclonal antibodies that aim to enhance the immune response against multiple solid cancers in dogs, and 2 of these are currently in clinical trials for dogs with oral malignant melanoma and bladder cancer. Now I will pass it on to you, Dr. Mason.
Thank you very much. Let me just put my slides up here, share my screen. I think, Mandy, you're going to need to give me access to share my screen. There we go. Perfect. Okay, now everybody can see my messy desktop. Okay. All right. So thank you so much for this opportunity. It's really exciting to be able to sort of share some of this work with you. We've had a number of greys on clinical trials over the years. And I have to say, I'm really partial to them. I know I shouldn't say that, but I'm very partial to them. They're fabulous dogs. And also, I have to say that they're often the best dressed dogs. So oftentimes we will, in fact, see them coming in with ties and bunny ears and all sorts. So they really do well here. I'm just going to get myself a laser pointer here. Can you see the pointer? hopefully you can. So it's a beautiful day today. Spring has sprung. And what I'm going to try and do is put sort of a hopeful spin on treatment of dogs with osteosarcoma, because I think there is a lot of hope here. And at the end of this, hopefully you'll agree with that. So I'm sure many of you are more than familiar with osteosarcoma, bone cancer. It affects large and giant breed dogs. We know that greys are overrepresented. The racing greyhounds are overrepresented. It tends to occur in middle to older age dogs, so 7 to 9 years of age is sort of the peak incidence, but there is also another peak incidence at between 18 and 24 months. Far fewer dogs in that much younger category, but we do see a little group there that will develop osteosarcoma. There's a slight sex predilection for males, more so than females, and then for neutered animals, more so than intact animals. And if you've had a patient or a dog with osteosarcoma, you will know that the initial signs are frequently lameness. And this is because these tumors really are quite painful. Classically, or most commonly, these tumors occur in what we call the appendicular skeleton, which are the bones of the legs, essentially, but can also occur in the axial skeleton. So, for example, in the skull and the vertebrae. When we teach the veterinary students, we'll say that osteosarcoma occurs away from the elbow, so here in the proximal humerus, and in the distal radius, and towards the knee, so in the distal femur and the proximal tibia. So away from the elbow and towards the knee. These are classic sites of osteosarcoma. And if your dog is lame, and perhaps they will show initial response to some anti-inflammatory drugs, but eventually they will have a radiograph performed, and then this is the sort of picture that we will see. So here you can see a proximal humerus tumor that we would take a look at from the radiographs. There's areas of lysis, so that's where there's sort of darker spots within the bone, and you compare it down here to the normal bone. So we see areas of lysis. We see areas of new bone deposition, as you can see around the edge here, what we call sort of a palisading pattern of bone being laid down in these sort of columns. And then we see cortical bone thinning as well. And you can see that a little bit better on the other view of this particular lesion. And so this is really all an indication that the tumor is sort of eating away at the bone and making the bone quite weak. And that is why we can get what we call pathological fractures, where with this area of lysis, bone lysis and breakdown, that makes the bone weak and vulnerable to fracture. And sometimes those lesions will also be biopsied to confirm the diagnosis. There are other tumors that look sort of similar to this, but in the majority of cases, when we see this in a breed that is susceptible to osteosarcoma, it's most likely to be osteosarcoma. If there's a doubt, it would need to be confirmed with biopsy or at very least aspirates of that lesion. Standard of care is amputation plus chemotherapy. And the reason for that is these are painful tumors. We know that because we know the way the dogs react. If you just gently squeeze on these areas, it's very painful. And we also know that children that get the same disease also describe this tumor as being very painful. So that the fastest way to get rid of this painful area is amputation. And then the biggest issue with this tumor is the fact that it spreads, and it spreads early. So it is not the primary tumor that kills the patient, but the fact that these tumor cells peel off from the tumor and then go somewhere around the body and set up another site of cancer. And that's frequently in the lungs. And it is this metastatic disease, this spread of the disease, which is the problem. And that is the reason why we will follow up amputation with chemotherapy, cytotoxic, meaning cell-killing drugs that will actually try to inhibit and kill rapidly proliferating cells, which are thought to be the cancer cells. Despite standard of care, the survival times are relatively short, between about 8 to 10 months. That's on average. Some dogs don't live that long, other dogs live longer, but the average is about 8 to 10 months. And unfortunately, even though we have tried very hard, over the last 40 years, there has been no improvement in survival in dogs with osteosarcoma. And also there's been no improvement in children with the same disease. So these are Kaplan-Meier survival curves, which I'll show you a couple throughout. And just to orientate you, on this axis here, the y-axis is survival, and on the x-axis, which is along here, is the number of days. So as we see this curve dropping off, this indicates patients that either are developing disease, so this is the disease-free interval, or in this curve, it's overall survival. So these are patients that the curve drops down as the patients die on the study. And this is a recent study by Amy LeBlanc from NCI, using rapamycin to actually see if you can improve outcome. And you can see that the standard of care and the rapamycin curves overlap, meaning that there's no effect of that drug on the outcome. And we see this throughout. And I've just put some of the multiple manuscripts and papers reporting clinical trials in dogs with osteosarcoma, trying to use different chemotherapies, trying to add in different drugs like gemcitabine or toceranib, which is Palladia, or piroxicam. You can see in all cases, these curves sort of drop off, and the median survival time really doesn't change for, around about 300 days, something like that, 250 to 300 days. So even though we've been trying for decades, we haven't made an improvement, and these dogs die of metastatic disease. The current treatment options, as I've already mentioned, are amputation. The good thing there is rapid elimination of pain, rapid recovery time, particularly in the agile greys who can sort of get up and run around on 3 legs pretty well. Limb sparing surgery is where we try to preserve the limb, and often we'll cut out the tumor and replace it with a bone allograft, often from a cadaver dog. And these have very prolonged recovery times, and oftentimes will get infected, and we're going to talk about that in a minute. So these dogs will still die of metastatic disease within about 8 to 10 months, and they have a very long, protracted survival time. So oftentimes people will choose to amputate rather than do limb-sparing surgery, because the leg comes off within 2 or so weeks. These dogs, or even sooner, these dogs are up and running around, and they have an excellent quality of life until they succumb to metastatic disease. The limb-sparing surgery dogs have a much longer recovery time from surgery. Radiation therapy, there's 2 types. There's palliative radiation, which really just acts to try and alleviate the pain that is experienced from this tumor. And there's also stereotactic radiation, or cyberknife, which is a lot more powerful. And if we combine that with chemotherapy, we sort of get similar results to amputation and chemotherapy. And then chemotherapy, as I've said, is used to go after those malignant cells, those cancerous cells that have peeled off from the tumor and have gone around the body. We can't see them, but we know they're there, because almost all of our dogs will succumb to metastatic disease. So chemotherapy after amputation has been shown to improve survival times, and is in fact used to try and go after those metastatic cells. But what I want to sort of talk about more today is a sort of a newer way of thinking about treating these and other types of tumors, and that is using the immune system. So we all know that our immune systems are there to protect us from viruses and other bacteria and other pathogens, and also protect us against cancer. And so the idea here is to use the immune system, to sort of use drugs, if you like, in a way to manipulate the immune system. And then the immune system will go after the cancer. And this makes a lot of sense when we talk about metastatic disease, because early on, these metastatic lesions may just consist of 1 or 2 cells, 1 or 2 cancerous cells, and we can't see them. We can't cut them out. We don't know where they are. Nobody knows where they are. We can't use radiation because we don't know where to direct the radiation. And the only thing we've really got is to sort of flood the body with chemotherapy, with hoping that that chemotherapy will kill off some of those malignant cells. But the immune system can find these cells. The immune system basically produces sort of immune surveillance. So it looks around the body all the time, constantly. Cells are moving around your body looking for viruses, looking for bacteria, looking for cancer cells, finding them and killing them. So the idea of using the immune system is just that. So how do we know then that osteosarcoma is immune responsive? And we can actually go back over 100 years to this chap here, William Coley. And he was a bone cancer or bone surgeon at what is now Memorial Sloan Kettering. And what he noticed was a number of his patients, human patients coming in that had bone cancer. Oftentimes, these patients were also suffering from what was then known as erysipelathrix or streptococcal infections. So back then, antibiotics weren't around, and a lot of patients often had concurrent bacterial infections. And he noticed that those patients of his with bone cancer that had bacterial infections tended to do well, tended to do better than those patients that did not have concurrent bacterial infections. And I think the genius of Bill Coley was to put those two observations together and then to say, well, what would happen if we took human patients that had cancers but didn't have a concurrent infection and actually infected them, gave them bacteria? So that's something, of course, you really couldn't do nowadays because of FDA oversight and so on. But he started to do this, and he used Coley's toxins to actually, which is a mishmash of bacteria, to inject these patients. And he found that some of these individuals went on to do very well. And that really was the start of this sort of immunotherapy revolution that we're in the middle of now. And you can see from these papers that I've just put here that we now, 100 years later, are recognizing the same situation in our dogs with osteosarcoma. So these are papers mostly from surgeons who are doing limb-sparing surgeries. And as I mentioned earlier, oftentimes these dogs will get infected. About just shy of 70% of these dogs will develop infections following this very long and complex surgery. But what has been found in each of these manuscripts is that those dogs that get infections following limb-sparing surgery survive almost twice as long as those patients that do not get infected during or after limb-sparing surgery. And so what this is telling us is that that bacteria in some way is activating the immune system, and that is leading to a prolonged survival time. And so from that clinical observation, we can actually start to do some really sort of very high-tech, complicated molecular analysis of tumors. And this is work from Amy LeBlanc at NCI, and just walk you through this. So these are these survival curves again. So as the curve drops down, these are dogs that are dying. And what she had done is she looked at the actual tumor from these dogs and asked the question, do I see evidence of immune cells in the tumor? Do I see evidence that the patient's immune system is recognizing that that tumor is there and is actually infiltrating the tumor? And so this is what we call immune enriched tumors. And you can see it's in this purple line here. And then we have immune-enriched tumors that have a little bit more stroma, a little bit more parts of the tumor that are in the lighter pink. And then we have immune desert. And these are canine tumors where there's no evidence of immune cells, no evidence of what we call T cells, which are sort of the soldiers of the immune system, the killer soldiers of the immune system. And you can see that if you have lots of T cells and natural killer cells, immune cells in your tumor, you do better than if you do not have them. So the dogs that have no evidence of an immune response in their tumor do not survive very long, whereas the dogs that do have the evidence of immune cells in their tumor telling us that the immune system is recognizing that the tumor is there, those dogs do better. And some of them go on, for longer term survival. So this tells us that the immune system, together with William Coley's observations and the observations of our surgeons doing these limb sparing techniques, and even now with all this molecular analysis, that tells us that the immune system is having some effect on these tumors. So really, when we think about immunotherapy, what we're trying to do is we're trying to sort of stimulate a very sort of broad anti-tumor immune response. And we can do that in a number of ways. And really, the overall goal of immunotherapy, and this is key to remember, the overall goal is to generate T cells, which are these killer cells that we've been talking about a little bit about, to generate a lot of those T cells that can go to the tumor, be it the primary tumor, in other words, the tumor in the leg, or be it the tumor that's spread somewhere else in the lungs, perhaps, or elsewhere. These T cells can circulate around the body, find those malignant cells and kill them. So there's a number of ways in which we can end up with making these sort of T cells. We can start with vaccines, and I'll talk a little bit about the Listeria vaccine. And the idea of vaccines is they will actually utilize all the sort of other immune components in the immune system to generate these tumor-specific T cells. And so we're depending upon the body to make those T cells when we use vaccines. Or we can actually start to take T cells from the body, take them outside of the body, and instruct them and tell them that they need to find the tumor and go after the tumor, and then put them back into the body. And we'll talk about two of those approaches as well. So let's start with vaccines. And I just want to give you an update on the Listeria vaccine. So Listeria, as you know, is a bacteria we classify as a gram-positive bacteria that likes to grow in areas that don't have much oxygen. And it's a very common cause of food poisoning. So in processed meats and in cheeses and so on, it causes fever, causes very severe gastroenteritis, vomiting and diarrhea, and also particularly in our larger animals like sheep and so forth, it can cause encephalitis and abortion. And the reason that it causes fever and gastroenteritis is because it's really a hugely potent stimulus of the immune system. And when your immune system is super activated, it can cause fever, it can cause vomiting and diarrhea. So oftentimes the symptoms of food poisoning are because the Listeria is causing such a big stimulus to your immune system. So fortunately, it will rarely cause serious illness that can't be controlled with antibiotics. But sometimes if the patient is elderly or immunocompromised, it can be very serious. But because it can stimulate the immune system so much, it's an attractive option for some type of immunotherapy. And we can also genetically engineer the Listeria, one, to make it much weaker so it doesn't cause all these terrible side effects of massive immune activation. And also we can engineer it to express a molecule called HER2/neu, which is often found in osteosarcoma tumors. So really what we're doing is we're using this Listeria a little bit like William Coley did to actually sort of give this to the dogs and use the Listeria to stimulate a very strong immune response against this molecule, HER2/neu. And so we'll have lots of T cells specific for this molecule, which is found in tumors. And those T cells will then go to the tumor and hopefully kill any metastatic lesions. And so when we first did this study, we decided we would look to see if this Listeria vaccine could actually delay the inevitable formation of metastatic disease if we gave it after standard of care. So our patients came in, they were diagnosed, they had amputation, they had 4 doses of carboplatin, and then only if they were free of metastatic disease in their lungs at that time, they would get 3 doses of the Listeria vaccine, and then we would just follow them up. And they had the opportunity to have repeat vaccinations as well. And all the dogs had to have evidence of HER2 in their primary tumors to enroll on the study. And so what you can see here, again, this is one of our survival curves. And you can see that when we vaccinated the dogs, they survived a lot longer than the dogs that were not vaccinated. And this was a historical control. You can see that there's a gap between the two survival curves. And that tells us that this group here is doing better than the group that weren't vaccinated. So just moving on, I know we don't have a huge amount of time, so just moving on, what about if we were to use this vaccine earlier on in the course of the disease? And in fact, we could take it one step further. What if we were to combine this vaccine with radiation of the actual primary tumor? And we did this because obviously a number of people don't want to amputate the limbs. And could we actually combine an immunotherapy with radiation therapy, combine the two together? And would that be beneficial in stimulating these T cells, these killer cells, to not only go off around the body and try and kill little bits of tumor that have peeled off the primary tumor, but could it also stimulate T cells to come back to the tumor and actually start to kill the primary tumor? Is that a possibility? So we started a clinical trial, and we wanted to combine the vaccine with palliative radiation. So this is not cyberknife or stereotactic. This is low dose palliative radiation. And you can see here, these are just archived pictures or radiographs from dogs that just received palliative radiation to show you radiographically how bone tumors change with time, and they advance. So palliative radiation does not stop the tumor from advancing and growing. So you can see here in this patient, over 3 months, the tumor has gone from this, where we can still see a relatively normal looking leg here or bone here, to this. So a lot of soft tissue swelling, a lot of lysis and sort of proliferation of bone here. So pretty rapid advance over 3 months. And similarly here, you can see over a fairly short period of time, 3 months, progression of this tumor. So these are dogs that had palliative radiation, and median survival time with radiation alone is about 136 days. So, radiation alone is not the answer. So what happens if we were to combine radiation with vaccination? And that's exactly what we did here. And this is the study design. 2 doses of radiation on consecutive days here. We actually biopsied all these tumors to show that they were indeed osteosarcoma. 2 doses of radiation. And then we vaccinated these patients. And we sort of followed William Coley, who kept vaccinating his patients back in the 1800s. And we gave them 8 doses of this vaccine, the Listeria vaccine. And then if the owners wished, they could come back, bring the dogs back, and we gave them a booster every couple of months. And I just want to show you what happened in a couple of these dogs. So this was a Great Pyrenees, lovely dog, beautiful lady who would come up from South Carolina and drive the dog up to Penn pretty regularly to get her vaccines, obviously. And you can see here the primary lesion in that proximal humerus. So we vaccinated this Great Pyrenees. And Queen Sheba was her name. And we gave her full course of vaccines, and she came back 5 months later, and we were quite pleased with that. We thought, gosh, she's doing quite well. But when we radiographed her, we could see that the tumor had progressed. Nevertheless, the dog was doing well. She had a relatively low lameness score, which is down here, and off she went back to South Carolina. And then she called us up, and she came back in November. So this is 10 months later. And you can see that the tumor really hasn't changed. In fact, it looks a bit better. There's less soft tissue swelling. And then she came back in January, and the tumor looked about the same. And then she came back a year later, and you can see the tumor has progressed quite substantially then, but the dog remained really not very lame. But this is a 2-year survival. And at that 2-year point, she still had no evidence of metastatic disease in her chest. And so this is, I don't know if this is going to play. I'm not sure this is going to play. Let me just see here if I can make this play. Yes, here we go. So this is her coming along in February. You can see that she's a little lame there on that left fore, just bobbing up and down. This is her now a year and a half later. And you can see that she's seeing really no adverse effects of that osteosarcoma. She's color-coded in blue, so you know which one she is, because the lady had 2 of these. So really quite remarkable 2-year survival period. But then keeping the leg on was also impressive. And this is just another dog as well, where you can see a big German Shepherd called Luke, beautiful dog. July of 2014, here's the disease. We biopsied it, confirmed osteosarcoma. And you can see that really we don't see an awful lot of change over several years until we start seeing some proliferation again. And he also remained free of metastatic disease. So quite remarkable responses there. And we did this in 15 dogs, and 5 or so of these dogs went on to do quite well. Obviously, I'm showing the best dogs, and both of these dogs lived about 2.5 years before eventually succumbing to their disease. So what I hope I've sort of started to drill in is that T cells are really important. Immune cells are really important in this disease. And so by using vaccines, we're sort of trying to tell the body, hey, you need to make lots of T cells that will go and find the tumor. But there's another way of doing that, because maybe the body isn't that great at doing that, particularly in cancer patients, for reasons we can discuss if you're interested. So one of the other approaches we can do is we can sort of act like this sergeant major here, and we ourselves can actually instruct the T cells, which are shown here in blue. We can order them to go and find the tumor, the metastatic cells, and kill them. And the way we instruct them and order them to do this is we can take them out of the body and we can give them a receptor, this funny little thing here called a CAR, a chimeric antigen receptor, that will basically instruct them, if you like, to go and find malignant cells and kill them. So this is a very advanced genetic engineering approach, and it's called CAR T cells, chimeric antigen receptor T cells. And we are now doing this approach, performing this approach in canine patients. We can make canine CAR T cells, and we can actually direct them against osteosarcoma cells. So this is work out of Northwestern University. They've made canine CAR T cells that are specific for a molecule on the surface of the osteosarcoma cells. Sorry, I've lost my pointer. Here we go. And so the osteosarcoma cells are in green here, and this is a time course after they've co-cultured them with these CAR T cells. And you can see that when you put them with these particularly instructed T cells, where we've told them to kill the cancer, you can see all the green goes away. These cells are very effective at killing these organoids, these osteosarcoma clusters, if you like, in vitro. And we can actually do this in dogs, and we have clinical trials running in dogs with lymphoma. So this is our team here. This is a patient with lymphoma. He's heavily sedated, and he's having an apheresis procedure. So blood is coming out of him into this machine here. This is a Spectra machine, and that machine is like a giant centrifuge, and it will spin his blood, and these are the white blood cells in his blood. It will separate out the white blood cells from the red blood cells, and we want these. We want the white blood cells. And the machine will pump these white blood cells up into this bag and put all the red blood cells and all the plasma and everything else back into the patient. So this is apheresis, and this is what will happen to you if you have to have CAR T cell therapy for your cancer. You will undergo this process of apheresis, and dogs tolerate this process very well. It takes a couple of hours. And then we can take these cells and we can process in the lab. So what we do is the patients undergo apheresis. We will isolate out their T cells, and then we will instruct them. And we do this with a virus. And I can tell you details about that if you're interested. And we put these little receptors on the surface of these cells. We expand them outside of the body. So maybe we start with 1 million and we end up with 200 million. And then we put them back into the patient. And so we've done this in dogs with lymphoma, and this is a complicated slide, but there's one key take-home point. So these are CAR T cells that we have instructed to kill cancer cells that express a molecule called CD20. So you can see in this particular dog, Harley here, these are flow plots. Each dot is a cell, and these are markers of B cells, CD20 and CD79A. What's important here is you can look to see that this dog has a lot of B cells in his peripheral blood and a lot of B cells in his lymph node. And these are all malignant cancerous B cells, and they all express this molecule CD20. And we give this dog a single injection of his own T cells that we've redirected, we've instructed them, go and find CD20 positive cells and kill them. And you can see by day 138, this dog has lost all his CD20 positive cells. These CAR T cells have killed all of those cells. So this is a very effective way of engineering these T cells to go and kill these tumor cells. Now, there's some issues which we can go into. This dog relapsed with a CD20 negative disease, and that is certainly issues that we see in humans as well. But the proof of concept is there. We can take T cells from a patient, we can order them to go and kill target cells, and they will do so when we put them back into the body. Now, that's what we have done, what's called an autologous situation, where we have the patient undergoes apheresis, and we use the patient's own T cells to instruct those cells and put them back into the same patient. But as I alluded to earlier, sometimes the immune systems of these dogs are not very healthy, probably in part because they have cancer. So perhaps a better approach would be to actually use a donor dog that has healthy T cells that aren't affected by cancer, and to do pheresis on that healthy donor dog and generate cells that we could then put into the patient dog. And the idea then would be that we can actually select these healthy dogs for the best cells that they have. So we can look at 10 donors and choose the one who has the best cells and basically perform apheresis and give the healthy, fit, fighting T cells to the patient. And so again, this is complicated, but really what I want you to focus on is this cell here. So we've talked a lot about T cells. There is another cell called a natural killer T cell, which is a very low frequency in the peripheral blood, but very, very potent, and is able not only to kill the tumors, but also can kill immune suppressive cells in the tumors, so cells that sort of try and fight against the immune response, and is also sort of like a conductor of the orchestra. They can actually conduct other cells of the immune system to kill against microbes, but also against cancer. But the beauty of these cells is, for reasons that I'm not going to go into, we can actually take these cells from a healthy dog and we can put them into another dog without having to do any form of engineering and without having to worry about graft versus host disease. And so we can find healthy donor dogs that could donate their NKT cells that can then be engineered to be further instructed to go to the cancer with a CAR. And we actually have a clinical trial starting now, well, in the next 2 months. So it's not open now, starting in a couple of months, to use these CAR iNKT cells for dogs currently that have metastatic disease. And then our second study will be to use these cells to prevent metastatic disease. So these will be basically dogs who have undergone amputation and follow-up chemotherapy. We'll screen them to make sure they're eligible. They will have metastatic disease. They have to have a target in their tumor as well. And then they have a very low dose single injection of chemotherapy. And then they receive a single dose of healthy donor iNKT cells that have been engineered to go after the metastatic osteosarcoma. And then they will have a number of visits in which we follow them up. We look at their blood, we look at chest radiographs for the first month, and then we look at them monthly. And we're really trying to understand if this cellular approach is safe, if it's tolerable. We'll be doing dose escalations. If these cells can persist, and we have data to suggest that they can in mismatched dogs, and the anti-tumor effects. So the last thing I want to say before we stop and go to Q&A is that we've talked a lot about T cells, and we've talked a lot about T cells going to the tumor and infiltrating into the tumor. And when they are there, they can start to kill the tumor. And I just remind you of this survival curve that we had seen earlier, where those cells, those dogs that have a lot of immune infiltrate into their tumor do better than those dogs that do not have any evidence, in the blue here, do not have any evidence of an immune response. So the immune cell infiltrates in osteosarcoma patients. Those cell infiltrates into the tumor predict survival. So it therefore follows that those cells that are in the tumor are sort of attacking the tumor and trying to sort of control it. And maybe they just need a little bit of extra help. So this is work from Sita Withers, and she's showing that there are dogs, just as I showed here from the molecular analysis, that have no T cells in their tumor. Those are the immune desert dogs. Those are the blue here, the dogs that don't survive very long. And then there are other dogs where there clearly are T cells, and those are shown by the sort of purpley pink spots here, where there is a T cell response in there, and that those T cells are trying to do something. They're trying to work against the cancer. And so these are called tumor infiltrating lymphocytes. Makes sense, right? T cells that are going into the tumor infiltrating lymphocytes, or TILs. And we think that the tumor itself is a really good source of T cells. And so one of the ways in which people have been trying to combat a variety of tumors is to use TILs. And so what they do is they cut the tumor out. Obviously, that's happening with dogs that are undergoing amputation. They cut the tumor out, and then they can isolate the T cells, shown here in green, from the tumor, and they can actually stimulate them, and we can actually engineer them as well to make them even more potent, and expand them outside of the body again, so proliferate them, so now you have a ton of them, and then they go back into the same dog, where they will hopefully then go around the body and find the metastatic cells. So we think that the tumor is a place to look for these T cells and see if we could isolate the T cells from those tumors, and if we could possibly expand them and even engineer them to make them more potent to attack the tumor. And so this is work, this is my second to last slide, I think. This is work that's being done by a very talented combined degree student in my lab, Kay Foos, who is basically taking tumors from dogs that either have osteosarcoma or melanoma, and basically isolating out the T cells, activating those T cells, and expanding those T cells. Now, currently, and this is important, currently, this is purely experimental, and we have not got to the stage where we are reinfusing the dogs. Currently, we're just seeing, can we do this? Is it possible, even in dogs, to isolate these immune killer cells from their tumor, and to then see if we can make them, lots more of them, in a petri dish? And so this is what Kay has done. This is actually a patient with melanoma, where we've taken the leftover tumor that was sort of left on the table after excision, and we've been able to isolate the T cells. And you can see here, this is the fold change. So we start off with very few T cells, and the way that Kay has been stimulating them, within about 10 days, we have 200-fold expansion of these cells. And most of these cells we think are going to be specific for the tumor. And we can actually do an experiment where we look at secretion of a cytokine, and that tells us if the T cells are active. And so she's taken these T cells that she's expanded from a melanoma patient, and you can see if you just look at the tumor itself, there's no activation of T cells because it's just the tumor itself there. If you look at the T cells just sitting on their own, they produce a little bit of cytokine. But when you put the T cells with the tumor, that's when the T cells get activated, and that's when you see more cytokine. So what this is telling us is we're starting to develop an approach now where we can isolate those killer cells from tumor that's been left over after surgery. And rather than putting it in the bin, we can actually get something from it, and we can see if we can expand these T cells, see if they're functional, and then initiate a clinical trial where we could use this type of approach to see if we can delay metastatic disease. And so to end, I just want to say we really need your help. We need the help of the Gray community to allow us to take those leftover tumors if your dog has unfortunately been diagnosed with osteosarcoma, and if you have decided to proceed with amputation, then what we are asking is essentially for your permission to allow us to take that leftover tumor and see if we can isolate T cells from it and expand those T cells out and engineer those T cells. And so this is a QR code here, which actually is a video of what we're asking your vets to do after the amputation, when the leg has come off. Obviously, the primary concern is with the patient, make sure the patient is doing well and recovering well. But that limb has a lot of information in there for us that can help to push us forward as we try and understand the best way to stimulate the immune response. And so this is just an ongoing study. It has been very generously supported by GHI, and we're very grateful for that support. And it has enabled us to start doing this procedure, to start taking osteosarcoma cells. I showed you data from melanoma, but we have been doing this now in dogs with osteosarcoma, and we are able to expand these T cells out of these tumors. We've only done 2 so far, which is why we're really interested in looking to see if we can get more samples. Again, just to be clear, this isn't a clinical trial. We're not there yet. But if we could just get some buy-in, and if we could get sort of the community, the Gray community, to help us, we can really move forward together. So we're really excited about this study. Lastly, I just want to say, if you are looking for a clinical trial for your dog, I hope you're all aware of this Veterinary Clinical Trials Registry. There are a number of immunotherapy clinical trials ongoing for dogs with osteosarcoma. So please go to this website and have a look for trials if you are interested in looking at a clinical trial for your dog. I know most of the investigators, they're very friendly, and they're all really trying to do their best to make a difference in this disease. And then finally, just a shout out, if you're in the Philadelphia area, we have our annual Steps to Cure Sarcoma fundraiser. This is for humans and for dogs who have sarcoma, and you can register and come along. It's on May the 19th. We have a Canine Cancer Crushers team that you can join as well. Get a free t-shirt, and we're trying to raise $100,000 for sarcoma, and some of that money comes to the vet school to help us with our studies in sarcoma. And so with that, I'm going to leave it. I just want to acknowledge, you know, there's a lot of people whose work I've shown, and this takes I was going to say a village. It takes a sort of massive community really to do these types of studies. And I really want to thank the members of the Greyhound Health Initiative, Dr. Kuto and Mandy as well, who've been amazing in setting up this this study that we're trying to do with the TIL therapy. And with that, I'm going to stop sharing my screen, and happy to try and answer any questions that you might have.
Thank you. That was amazing. I am going to start reading the questions for you. Is that what you?
Yes, that's
Okay.
great.
All right.
Actually, I can see them here.
Okay.
So the first question is a great one. Are the immunotherapy bacteria the type of bacteria that is normally found in canine and human bodies or guts? That's a great question. So, so the answer is no. This is a bacteria that is not found in the body. It's not part of the gut microbiome. And it is the bacteria that usually causes disease. So it's usually the bacteria in sort of, you know, old cheese and deli meats and these sorts of things. But it has been engineered, it's been changed. We've taken the natural bacteria and we've mutated it so that it is a lot sort of a lot less healthy. It's very attenuated, it's very weak, and so it doesn't cause the same sorts of side effects that we see with the wild type Listeria. Then I have another question. Can you use other bacteria than Listeria? Great question. So I think the answer there generally is no. There's something, I didn't have time to go on about that, but there's something very unique about Listeria and the way it infects antigen presenting cells, which are part of the immune system. And it's because of that way that they infect antigen presenting cells and the activity that they have within those cells, which is unique to Listeria. I think Shigella does it as well, actually, but mostly Listeria, is why Listeria can produce this effect. So it has to be Listeria. So even though the X-ray looks better, is there still a chance of fracture? So I think that perhaps is alluding to the non-amputation study that we did. And so, yes, the important point to make there with those dogs that you saw in the videos I showed is they still have evidence of cancer there. I mean, we didn't go on and biopsy them again because you know, you don't want to risk a pathological fracture. But you'll notice that in those radiographs, the tumor did not go away. The tumor did not go away, but the tumor seemed to be held in both a clinical as well as a radiographic dormancy. It just sort of stopped growing. And so in my mind, that felt as though, you know, there was an ongoing battle, the immune system trying to attack the tumor trying to resist, and we sort of had a status quo for a while. And then after that, it seems that after sort of 2.5 years in those 2 patients I showed you, after that, we started to see the tumor winning. But the important thing was, I think we had initiated that giant battle and that immune system was chivied up and able to sort of control it for a period of time. And that shows us, I think, a sort of a chink in the armor of osteosarcoma, and we can start to make that wider. We've sort of got a handle now on the immune system can do something here, and we just need to help it along. And I think we're going to see better results. Okay, let me see. If my greyhound is diagnosed with osteosarcoma, what should be my next steps if I want to explore some of these new options? I'm in Ohio. Thank you. So thanks for that. So yes, absolutely. I think that there are a lot of studies going on. Please look at the AVMA website for clinical trials. Different clinical trials will do different things. Obviously, I'm an immunotherapist, so I'm interested in immunotherapy. And I think that's the way to go. Different trials will have different numbers of follow-up. They may require the dogs to have amputation. If you don't want to amputate, then you won't be eligible for that study. They might require a lot of follow-up, and people sometimes just can't do that. So you may want to go for a trial that has perhaps, you know, 1 or 2 visits a month rather than 10 visits a month, and so forth. I know that GHI, that Dr. Kuto and Mandy are fantastic resources as well for understanding the next steps as well if your dog is diagnosed with osteosarcoma. But I do encourage you to look at those studies. There's some really great work going on with immunotherapies, great work at Colorado State, great work at UC Davis, at Tufts, and down in the South as well. So, so don't lose hope is what I'm saying. Okay. Am I answering these? I just want to make sure I'm answering these in the correct order. What type of radiation was used for the treatment of keeping the leg and having 2 doses of radiation and then 8 doses of the listeria vaccine? Is this the current best option for keeping the leg? Also, was there a common side effect seen? So in that study, the radiation was palliative radiation. It was very, very low dose. So it was 2 doses of 8 gray to the leg on 2 consecutive days. So it was low palliative radiation. Obviously, that requires general anesthesia. So 2 days of general anesthesia for that type of radiation. So is this the current best option for keeping the leg? Well, I don't think we can say that, unfortunately. Unfortunately, the listeria vaccine is not available. We can't get hold of it. It's been taken into the human pediatric world. There's a clinical trial ongoing there. I think they've finished enrolling patients and we're waiting for the follow-up. I think that there's going to be some dependency on the results of that as to what happens with that vaccine. I think that, you know, there's information there about that vaccine. I do believe that that vaccine does something. But I do think it depends upon the dog as to whether it can work or not, if you want to call it that. And I think a lot of these immunotherapies depend upon the fitness of your dog's immune system. So is this the best treatment for currently keeping the leg? Unfortunately, we don't have this treatment now. It was a clinical trial from several years ago. So I think the answer, unfortunately, is no. At the moment, no, we don't have it. How do you find other clinics that are doing immunotherapy across the country? Are those clinics that were part of the listeria vaccine still doing immunotherapy? Yes. So again, go to the AVMA website. If you type in AVMA clinical trials, you will be taken to that website, and then you can type in osteosarcoma dog, and then you will see the studies that are on there. And any sort of decent study, as it were, any good study, it should be listed on that website. And then it will tell you which clinics are doing it. You can contact the study coordinators and they will tell you more about the study. Many of these studies, by the way, are funded already, fully funded through grants, through National Cancer Institute grants as well. So ask about that as well. Okay, no questions, Joseph. Thank you. Thank you very much. I'm sorry. I know that we've got a couple of these coming through about people whose dogs have passed away from osteosarcoma, and it's brutal, as you know. And I think all I can sort of say is we have to make a difference in this disease. We have to do better. And I think we can do that. And we can do that if we can engage the community like we're doing now, to try and fight against osteosarcoma, learn more about the disease, and push forward with clinical trials to make a difference. So would there be any advantage or even possibility to apheresis a healthy hound now and store the blood for T-cell extraction and engineering? Brilliant question. That's a great question. So the answer is yes. That is something that we have thought about doing. The apheresis procedure, I think the bottom line is we're not quite there yet. We're not quite there yet is the answer to that, because we don't know if this approach is going to work. The apheresis procedure is sort of expensive. It's about $1,200 or so to do that. But you are definitely on the right track. That apheresing the patients when they're, or apheresing dogs when they're healthy and storing their healthy T cells before those T cells get negatively affected by cancer makes a lot of sense. And I think that that's something we've been talking about in the human field as well. Do you sort of get apheresed if you're early on in cancer diagnosis? Do you get apheresed then, rather than waiting till you've failed multiple rounds of chemotherapy before going to an immunotherapy, and by that time your immune system is less healthy? So one day I think we will do that, but we're not there yet. Great question. If a greyhound is put to sleep due to bone cancer, can their tumor be donated, or does it have to be? No, absolutely. That's a very good question. So the question is, if you have to put your greyhound to sleep because of osteosarcoma, is it still possible to use the tumor, or does it have to be from a living donor? No, it is still possible to use the tumor. So, your patient, your greyhound would be put to sleep, and then what the vets would be able to do is take a small biopsy of the tumor and put it in special media, which we send to them. And that can then come to us, and we can start to do our studies on that. So they can still contribute to trying to make a difference here. So thank you for that question. Is there a test on the horizon to detect which dogs have a propensity to get osteosarcoma? I think the answer to that is no, not as far as I know. Dr. Kuto, feel free to jump in if you know of a test that's on the horizon here to detect, who's going to succumb to osteosarcoma. As far as I know, currently there's no available test. Can you address the Torogen vaccine and how it works? Yes. So the idea of the Torogen vaccine, as I understand it, is to actually take the tumor. So once, to take a biopsy, or if the patient is undergoing amputation, you can actually take the tumor itself, harvest the tumor, and then that tumor is then treated in some way. I believe it's either irradiated or a lysate is made. So basically they're breaking down the tumor and then putting it with an immune stimulant, something like, I don't know what the immune stimulant is. It's proprietary, but presumably there's some form of immune stimulant in there. And then taking that and using it as a vaccine to then put that back into the body. My thought there is I haven't seen results from the Torogen vaccine, and I think it's been around for a little bit of time. So I think it would be really nice to see if they've actually been able to show that can actually extend the survival of the dogs. I think that's important. I do believe that immunotherapy is going to help, but I think that the truth of the matter is we're probably going to need to use some combinations of therapy, just like I showed you with radiation and the vaccine together is probably, certainly it's more effective than radiation alone in some dogs that are able to respond. So that's the idea of the Torogen vaccine. I would be delighted if they would publish some data as to how effective that has been. Is there any indication that it's having some sort of effect? Okay, next one. My 8-year-old male has recently been diagnosed with a paraosteal osteosarcoma in his right tarsal bone. Can you speak to the difference in treatment and prognosis for this subtype? So we've not done any work with paraosteal osteosarcoma in terms of immunotherapies. As far as I'm aware, and again, Dr. Kuto can jump in here, but we treat them in the same way as the standard osteosarcomas. And so, prognosis as well. Again, I think we still have concerns about metastatic disease with these tumors. And so we're still looking for a way to stimulate the immune response against those tumors. Next one, I lost a hound to hemangiosarcoma. I think that's hemangiosarcoma. Could the same T-cell engineering approach be used for other cancers, including hemangiosarcoma? Hemangiosarcoma, I'm sorry, it's a really tough one. The key is to finding a target to go after on the tumor. And if we could find a target to go after, then it gets a little bit, it's a little bit more straightforward. Remember, we have to sort of instruct the T cells, whether it's by vaccine or whether it's by engineering, we have to instruct the T cells to go after something. So we need to find a flag, if you like, on the surface of the tumor, such as HER2/neu in the osteosarcomas, or B7H3 in the CAR T cells. So it's really sort of finding a target. Currently, people really aren't looking too much at immunotherapies for hemangiosarcoma. They're going more with immunotherapies for osteosarcoma, for some of the carcinomas as well. Hemangiosarcoma is a really tough one. Maybe one day we will be able to treat that with immunotherapy, but we're not there yet. Are you looking at dogs with osteosarcoma at all sites, for example, in the nasal passage or the rib? So currently, no. Currently, we're restricting it to appendicular osteosarcoma, simply because that's more common, and we're able to get the tumor more easily. So at the moment, we're just doing appendicular. Hopefully, in the future, we will be able to extend on to what we call the axial osteosarcoma, so the skull and the vertebrae. Do the dogs with treated tumors have to stay on pain meds, and does the pain still persist? So that's a great question with the non-amputated study. So some of those dogs remained on pain killers, others did not, and they were actually able to come off painkillers. Or when I say come off painkillers, they may have been given an NSAID, on days where they were a little bit lame. But they're not on sort of fentanyl patches and these types of things for pain. So their lameness scores remained pretty low during the time where, again, I think that battle between the immune system and the osteosarcoma was ongoing. So their quality of life, which ultimately is the most important thing, their quality of life was very good throughout the study. Do you know why some dogs' osteo doesn't met in the lungs at all? No, is a very quick answer to that. Most of them met to the lungs. But sometimes, particularly in these immunotherapy studies, we actually see that when the dogs have had immunotherapy, and that can be an immunotherapy with many different types of immunotherapy, oftentimes we see that the tumor may not go to the lungs, but then it comes up somewhere else. It comes up, for example, on a kidney, or they might get splenic osteosarcoma, or some of the things that we've seen are skin osteosarcomas, so subcutaneous osteosarcomas. So it can the immunotherapy might keep the disease out of the lungs and delay that metastatic niche. But we do then sometimes see it popping up in other strange areas and reasons that we don't understand. Okay, we have a greyhound who underwent amputation, chemo, and had the limb sent to Torregen for vaccine and are now giving metronomic chemotherapy. On Facebook, there are a large number of osteosarcoma dogs, and anecdotally, it seems this combination has the dogs surviving the longest, some over 1,000 days now. Any comment on the Torregen vaccine and this three-step process? So that's fantastic. So again, I've sort of commented a little bit on what I know about the Torregen vaccine. It's interesting now that they're going with metronomic chemotherapy as well. Combinations of these types of approaches, I do believe, are the right way to go. Whether it's the combination of the Torregen vaccine and metronomic chemotherapy, I don't know. There certainly are dogs that will do well, and I'm not honestly sure whether it's associated with the vaccines, the specific immunotherapy, or whether that particular dog has a very, very strong immune system, and you just need to give it a sort of a boost. And that could be perhaps with the Torregen, it could be perhaps with Listeria, it could be with the CAR T cells. You just need to give it a bit of a boost, and keep boosting it to try and control the disease. Please tell us again what you tell vet students about typical locations. Oh yeah, absolutely. So it is away from the elbow and towards the knee. Away from the elbow, proximal humerus, distal radius, and towards the knee. Any comment on adjunct over-the-counter treatments such as the soy isoflavonoid, the turkey tail mushroom, and curcumin, which many patients are on? So I think that I don't have an awful lot to say about those. There are some studies out there about some of these sort of immunomodulatory agents, or agents that hopefully immunomodulate the immune system and try and sort of help it, stimulate it. I don't think we've really seen studies out there that have proven that it does that and that it helps. We also haven't seen studies out there that say that it hinders. So I can't really comment on whether that's a good thing to do or not from a scientific standpoint, because we just don't know. And we know that the gut microbiome, as we alluded to earlier, the gut microbiome is probably going to end up playing an important part in how your dog's immune system responds. And it's very complicated. It's not well understood, but we're certainly seeing this in human patients now, that the type of bacteria that are present in your gut can actually influence how you respond to an immunotherapy. So that's a crazy idea. And it's very new, and we really haven't touched the surface of that at all in dogs yet. But I think we're going to find anything that can perhaps alter the gut microbiome to a favorable microbiome, which we don't know what that is, might actually enhance the patient's ability to respond to immune modulation. And how these types of agents do that, we don't know. Have there been any studies on storing cord blood for dogs? Not that I'm aware of. And finally, is the tissue bone collection specific to greyhounds, or are all breeds welcome? Can you post all the slides, including the QRC for the vets? So yes, this is open to everybody, every breed of dog. We've started with the Greys. The Greys have very generously supported this study. And so, you know, we obviously have a fondness for the Greys, and we obviously are rolling it out for the Greys. But if your dog has osteosarcoma and they are not a greyhound, they can still contribute. They can still contribute. And we would love to have those tumors that are being taken off and just otherwise would be thrown away. Is this video being recorded? I believe it is, yes. In study dogs with osteosarcoma, have you come across any trends related to their diet? Meaning, have you noticed that dogs who eat a specific brand or formula tend to have this? No, we have not identified any specific diet that either predisposes or helps with responding to various therapies. Okay, I think we're done. What a lot of questions. That's fantastic. Thank you so much for all your attention and all those great questions.
Thank you very much. Thanks so much, Dr. Mason, for doing this. This was very educational. I think that both veterinary students and veterinarians will get just as much out of it as our owners. Really appreciate all your time and effort with this. Just so everybody knows, this is being recorded. You will receive a recording if you are registered. And then we'll be posting the recording as well on our website and on social media, so that anybody can watch it after the fact as well. I will also try to get the AVMA clinical trials search posted on there as well, so you can so you'll have easy access to getting into those clinical trials and finding them. And I just want to all right, I'm just going to share my screen one more time here. Thank you everyone for attending. Oh, I think you're seeing the wrong screen. Hold on one second. Let's try that again.
I can see the thank you for attending screen.
Oh, you can? Okay, good. All right. So thank you all for attending. If you want to, this QR code will further support the Greyhound Health Initiative and our research and webinars that we participate in. And you can follow us on social media. Any of the social media will do. I try to keep those up to date and post everything. I want to thank the rest of our board members that helped make this happen today, and Dr. Mason especially. And if anybody else has any questions, please let us know. Otherwise, we'll wrap it up.
That's great.
I think that's it.
All right. Thank you so much, everybody.
Thank you. Really appreciate it.
Bye-bye.
All right. Bye.